Thank you very much, Dr. Jaya Gayatri. So I'd like to thank Dr. Jaya Gayatri and Dayakar for giving this wonderful opportunity today. And I'll be speaking on the complications of the orbital cellulitis. The orbital cellulitis is wonderfully covered by Dr. Raj Lakshmi. Maybe there will be some overlap because they are so interconnected. Okay. So orbital cellulitis is has to be treated and monitored, otherwise it will lead to the complications. And I'll be talking about these complications. So Chandler was the one who described how the superficial eyelid infection can go into the deep orbital cellulitis and subperiosteal abscess, then orbital abscess and cavernous sinus thrombosis. So the subperiosteal abscess is a collection of the pus here between the periorbita and the orbital bone. And orbital abscess, it is a collection of the pus in the eye socket behind the orbital septum. And since the cavernous sinus, the orbit is connected with the cavernous sinus through the superior orbital fissure, this infection can track to the cavernous sinus and can lead to cavernous sinus thrombosis. About 10 to 15% of the cases of orbital cellulitis can develop the orbital abscess, and this is more common in the pediatric age group. The mean age is around 9 years of the age, and this is likely to be due to the more common sinus infection in the children in this age group, and also because of the anatomical risk factors such as a thin bony barrier separating the orbit from the ethmoid sinuses. So despite of the treatment of orbital cellulitis with IV antibiotics for 24 to 48 hours, if you don't see any improvement, or if the condition is worsening, then this should alarm you. Then you should think about the orbital abscess. So Dr. Raj Lakshmi has already told the symptoms and the signs of the orbital cellulitis, and all these symptoms are going to worsen. Like there will be persistent high fever, there will be severe headache and the malaise, there will be increase in the eyelid swelling, pain, redness, etc. There may be increased in the proptosis, and proptosis in case of subperiosteal abscess, it may be eccentric proptosis. And in orbital abscess, it will be axial proptosis with lot of chemosis and tight orbit, and there will be partial, it will progress to partial to complete ophthalmoplegia. Due to pressure on the optic nerve, it will lead to diminution of the vision further. So that will give you the suspicion that this is a orbital abscess developing. Now, once there is a worsening of the symptoms and the signs, then you should be alert, and this is an indication for the urgent imaging. So you should order a contrast CT scan of orbit and the sinuses, which will be good for diagnosing, and it will show you the abscess is present there in the orbit. Also, you can see the size of the abscess, the location of the abscess, and anatomical extent of the abscess, whether this is limited to post-septal or this is going into cavernous sinus, or this is involving the intracranial, it is going into the brain. This will also help you to decide whether to do exploration or drainage, to go ahead with exploration and drainage. MRI is also very good because this will tell you more about the soft tissues, but it will be better to order an MRI when you are suspecting intracranial complications. So this is a case of orbital cellulitis. Here you see the abscess, which is present in the medial wall of the orbit. And this is another case where you see the subperiosteal abscess again on the medial wall. So this is about abscess is more common in the medial side of the orbit in about 62% of the cases. Posterior abscesses are also present, has been seen in few studies, and these posterior abscess, they have a more severe kind of clinical presentation, and they require the more aggressive debridement also. No, you have to order you have to send the nasal swab or the conjunctival swab or blood culture if it has not already been sent. And this, most of the cases of orbital abscess shows the Staph aureus and gram-positive cocci. The gram-negative cocci has also been noted. Gram-negative organisms has also been noted, and these gram-negative organisms, they are associated with more complications. And this gram-negative infection is associated with mostly the dental infections. Now, if this condition is not treated, this can lead to blindness, to permanent blindness, and this can lead to the double vision, a permanent double vision, or the exposure keratopathy. The infection can spread to the brain and lead to meningitis, brain abscess, cavernous sinus thrombosis. The infection can go into the bloodstream and it can become systemic also. Now, this is an urgent condition. You have to manage this as quickly as possible, and requires a multidisciplinary approach. You need to involve the ENT colleague in this. And there is always a dilemma whether we should continue with the medical treatment or whether we should go for the surgical intervention. So usually in 56% of the cases, the only with the IV antibiotics broad spectrum, the condition is resolved, especially in the cases where the abscess is small size, where the abscess location is medially located abscess, and minimum involvement of the optic nerve. The surgical intervention is almost always required when the abscess is very large, that is more than 10 millimeters. Then there is no improvement seen with the antibiotics or with 24 to 48 hours, or there are signs of optic nerve decompression, such as a deterioration of the vision and involvement of the pupil. If there is an intracranial infection, again, we have to think about draining the abscess, and when there is a dental source of the infection, which is more aggressive form of the infection. Now, first, you have to go with a broad spectrum antibiotics. That is mostly the third generation antibiotics, and the metronidazole to cover for the anaerobes, and vancomycin can be given when you are suspecting a methicillin-resistant Staph aureus. It can be given as 1 gram BD for 3 days, followed by the clindamycin 300 milligrams 3 times a day, and it has to be given for around 10 days to 2 weeks. It should be followed by the oral antibiotics. So even after the patient has clinically recovered, you have to monitor the patient to ensure that the infection has completely resolved, and to see for the recurrence and also the sequels of the infection. So successful outcome with the broad spectrum antibiotics has been noted in about 56% of the cases. But if patient is already on the broad spectrum antibiotics, then we should start the antibiotic according to the culture and the sensitivity. Now, the surgical treatment involves the emergency canthotomy or cantholysis, drainage of the orbital abscess, subperiosteal abscess, and the debridement of the infected sinuses, which are the primary source of the infection for this. So whenever the orbit is very tight and you feel that it is causing the compression on the optic nerve, this will endanger the vision. So you can go ahead with immediate canthotomy and cantholysis. This is a very simple procedure. You give a local anesthesia on the lateral canthus and then take a sharp scissor and cut the lateral canthus, and then you release the crus of the lateral canthal tendon. Okay. So for the drainage of the abscess, we can go either through the external approach or through the endoscopic approach. And the objective for draining the abscess is to reduce the infective load of the abscess and to reduce the pressure inside the orbit. And also we can send the culture for the specimen for culture sensitivity and for the biopsy. So external drainage, if the abscess is pointing directly on the skin and the conjunctiva, then we can give a free incision on the skin and we can drain the pus directly. Also for the posterior and the lateral abscess, which is not approachable by the endoscopic route, then we can go for that cases also, we can go for external approach. The endoscopic drainage is usually good for the medially located abscess. Here we can assess through the ethmoid sinus. So this is a video borrowed from my colleague showing the drainage through the endoscopic approach. So you have to debride the endoscopic sinus where the primary pathology is lying, and then you can remove the bone and then can drain the abscess endoscopically. So 78% of the cases, complete resolution can be seen in the 4 weeks, and there is improvement in the vision in 80% of the cases. But in the severe cases where the optic nerve is already been damaged, so there will be some visual deficits may be present. Close monitoring is very important in this case to see for the recurrence. So next complication which you see, which is not very common, but it's very life-threatening, which is cavernous sinus thrombosis. Cavernous sinus thrombosis means blood clot in the cavernous sinus. So this anatomy has already been discussed by the previous speakers. So this is a sinus which receives the blood from the cortical veins and from the superior and inferior ophthalmic veins. And it is located in the middle cranial fossa in the skull on the either side of sella turcica, and it lodges the important nerves and the vessels. So it is also known as an anatomical jewel box. And these are the important nerves. This is third nerve. This is your fourth nerve. This is ophthalmic division of fifth nerve, ophthalmic division of the, maxillary division of the fifth nerve. Here is your sixth nerve, and this is internal carotid artery, which is surrounded by the sympathetic plexus. So this is the blood from the superior and inferior ophthalmic vein will come here. This is a superior ophthalmic vein. So which will receive, which is formed by the supraorbital vein, supratrochlear vein, by the angular vein. This vein will drain the superior part of the orbit, and it will drain into the cavernous sinus. This one is the inferior ophthalmic vein, which is connected to the facial vein and to the pterygoid plexus of the vein. This will go either drain into the superior ophthalmic vein, or this will drain into the cavernous sinus. Now, this cavernous sinus will drain into the basilar plexus through the superior petrosal sinus and inferior petrosal sinus. So very key important characteristic of these sinuses is that these are all valveless sinus. So this will allow the bidirectional flow of the blood, which will depend upon the pressure gradient. So any infection either in the orbit or in the midface or in the dental infection can easily track down to the cavernous sinus and can cause the cavernous sinus thrombosis. Now, cavernous sinus thrombosis can be aseptic and it can be septic. Septic cavernous sinus thrombosis is not that very common, but it is very life-threatening. After knowing all the tributaries of the cavernous sinus, you know all these infection, orbital cellulitis, acute sinusitis, even the preseptal cellulitis, dental abscess, they can be very dangerous and life-threatening. So with treatment also there is high mortality, that is 20% mortality. And untreated cases, there is 100% mortality. Again, this is more common in the children, and immunosuppression resulting from the uncontrolled diabetes mellitus or the steroid use or the cancer or chemotherapy drugs are the risk factors for the cavernous sinus thrombosis. Now, all the symptoms of the orbital cellulitis will worsen in the cavernous sinus. So first earliest symptom is limitation of the abduction, which is due to involvement of the sixth nerve. And this will progress to the partial ophthalmoplegia to complete ophthalmoplegia. And involvement of the other eye is the another indication that it is going into the cavernous sinus because of the communication between the two cavernous sinus. You may see bilateral proptosis, which will give indication of the involvement of that this is a cavernous sinus thrombosis. All the symptoms, there will be rapid worsening, like which includes the fever, which has a particular pattern, which is known as picket fence fever. There will be rapid rise of the fever and then coming back to the normal. This is due to the involvement of the lateral wall of the cavernous sinus. The headache will worsen in 50 to 90% cases. The ocular pain will worsen. There will be more congestion of the facial, conjunctival, and the retinal veins. The severe periorbital edema and the deterioration of the vision will be there. These all are indications of that it is going into cavernous sinus thrombosis. Since the cavernous sinus, it has a very important neurovascular bundles. So some neurological symptoms will also be there. If there is an involvement of the sympathetic fibers around the internal carotid artery, it will lead to miosis, myotic pupil, or if the parasympathetic fibers or the third nerve is involved, it will cause the mydriasis. Due to the involvement of the fifth nerve, trigeminal division, ophthalmic division of the fifth nerve, there will be numbness, paresthesia around the eye, nose, and the forehead. Also, there will be the paresthesia of the face, entire face, due to involvement of maxillary division of the fifth nerve. Then the other symptoms are like rigor, stiff neck, confusion, seizures, meningitis, etc. You can also see the papilledema and the retinal hemorrhages. This is from one of the patient who developed papilledema. And this is because the drainage of the blood is obstructed in the cavernous sinus due to the clot. And this will lead to the venous congestion, and which in turn will cause the rise in the ICT and leading to the papilledema. So first immediate thing when you know that this is going into cavernous sinus, or when thrombosis, or this is you're suspecting a cavernous sinus thrombosis, is to do an immediate neurology consultation, then to go for MRI, and then check for the laboratory test. The WBCC, reactive protein erythrocyte sedimentation rate, will be very high, and the D dimer levels will be very high. D dimer, it is a byproduct of the fibrin breakdown. So it is produced when the fibrin clot is formed and it is broken down. So if there is less level of the D dimer, then it is less likely to be the cavernous sinus thrombosis. Other things, if the blood cultures are not already being sent, please send the blood culture, which will help you to start the antibiotics according to the culture insensitivity. And lumbar puncture may be required if there is suspicion of meningitis. The most important to confirm the diagnosis is magnetic resonance venogram. Now, this venogram MRV is a special kind of MRI which focuses only on the veins. So you are injecting a dye inside, and the cavernous sinus will be uniformly enhanced, and entire dye will fill uniformly into the cavernous sinus. But when there is a clot, you will see a filling defect because of the clot or absence of the flow in the cavernous sinus. Other features which will be seen is a dilatation of the cavernous sinus. There will be enhancement and convexity of the wall of the lateral wall of the cavernous sinus, which is usually concave. Thrombosis may be seen in the superior ophthalmic vein, and dilatation of superior ophthalmic vein, its tributaries will be seen. Other additional features which you can see on the MRI is carotid artery narrowing, cerebral infarction, intraparenchymal hemorrhage, subdural empyema, meningitis, brain abscess. That is why the MRI can give details of all these soft tissues. Hence, the MRI is more useful than CT scan here. Then since that there is a connection between the dural sinuses, we can, and this condition is associated with the multiple thrombosis in the other venous sinuses also. So we can evaluate the other venous sinuses also with MRI. Now this is a normal MRI, coronal image, T2 weighted image. This one is a lateral wall of the cavernous sinus. This is the lateral wall of the cavernous sinus. This one is a floor of cavernous sinus. And then this is a medial wall of the cavernous sinus. And here is the contrast, after contrast, fat saturated T1 weighted image. Here you see the dye is seen uniformly in the entire cavernous sinus. This is a normal scan. So this is, you can see dye is seen uniformly. There is no filling defect. These three small dots which you are seeing here, this one is a third nerve, and this is maxillary division, ophthalmic and maxillary division of the fifth nerve. This is a third nerve, and these two small tiny hypodense shadows, these are the trigeminal nerve. And here a small tiny shadow, hypodense shadow below the internal carotid artery is a fourth nerve. In case of cavernous sinus thrombosis, this will have the filling defects. Here you are seeing it is very uniform enhancement. In case of cavernous sinus thrombosis, it will be filling defect will be there. Now this is a MRI from a patient with a left eye proptosis. You can see the orbital abscess here, and you see the cavernous sinus of left side is slightly enlarged compared to the right side cavernous sinus. This is a venogram. So here you can see that there is a filling defect in this transverse sinus. So this is a transverse sinus thrombosis associated with cavernous sinus thrombosis. Now this is a normal CT scan again. So you can see again with CT scan also we can capture few features of the cavernous sinus thrombosis, because this is contrast enhanced CT scan. So you are seeing this cavernous sinus here, which is homogeneously enhanced on both the sides. If there is a cavernous sinus thrombosis, you may see some filling defect. Here again, you can see they are equally enhanced on both the sides. So if you don't treat, this condition goes untreated, then it will lead to meningitis, subdural empyema, brain abscess, and through jugular veins, it can also lead to pulmonary complications such as pulmonary abscess, pneumonia, and pleural empyema. Stroke can also be there. Directly, it can affect the pituitary, and it can lead to hypopituitarism or also to by ischemia. Now we have to do the immediate treatment of this. Mostly this will be done by the neurologist only, but we should have knowledge about this. So again, the treatment is the third generation cephalosporin and metronidazole for anaerobes, and then vancomycin for methicillin resistant staph aureus. And this treatment has to be has to be continued for long, that is 2 weeks beyond the clinical resolution. And this has to be combined with the anticoagulation therapy, and this anticoagulation therapy also needs a long-term treatment, that is weeks to months. The combination of anticoagulation and antibiotic can decrease the mortality from 4%, 40% to 14%, and also the neurological morbidity can be reduced from 61% to 31%. So corticosteroid is little controversial, but this reduces the inflammation around the nerves. So you can, if you want to give, you have to start the antibiotics for a few days and then start the corticosteroids. Surgical intervention, we have to debride the primary source of infection, and if some abscess is present, we have to drain that abscess. As such, no direct surgical intervention of cavernous sinus is required. So the takeaway is the early recognition and diagnosis is very, very important. As an ophthalmologist, mostly our role is to diagnose it at the earliest. And we have to involve neurologist and our ENT colleague in this. And with appropriate imaging and with the aggressive antibiotic treatment, we can save these patients. Thank you very much.